Now, as Pankaj said, how not to miss carpal instability. I mean, that's a very often missed kind of injuries, and we always feel bad that somebody missed it. And in the next few minutes, I would probably give some tips as to how not to miss this. Now, if you look at this, the wrist itself in terms of the anatomy of the wrist here, so you see that there are so many ligaments, and if there are injuries to any of these ligaments which are interlinking these small carpal bones like this, and probably it will be all scattered in like a string of pearls, and that's what happens, and that is the basic idea of carpal instability. Now, very classically, if you look at the history of this patient, these are young patients most of the times, but then they would come with the history with the fall usually 1 or 2 months later, because most of the time the injuries are missed, or it's sometimes treated as a small sprain and sent off. And generally, most of these would complain of radial sided pain, and they would have these kind of x-rays. Now, anybody would definitely miss these injuries. If you look at this complete jumbled up anatomy of the wrist, it's very complex anatomy what you see here, and that is why it is missed. And I would come to tell you why this is so much more complex. So the possibilities in a radial sided pain, all of us know, could be a distal radius related injuries. It could be scaphoid fractures, or one of the things which is commonly missed is the scapholunate. And this is the harbinger of carpal instability, the scapholunate injury. A good clinical examination is paramount for these things. And as I said, the scapholunate is the area which is the most common carpal instability pattern we see. And that's where the whole instability starts most of the times. The injury patterns can be different in some patients, but this is the commonest one. So to understand instability and not to miss them, what should we do? We need to know how normal wrist x-rays look, which Bipin has already told. And so we need to take the standard x-rays, which is the PA for the wrist and not the AP, and then lateral and the oblique views. So this is the thing which the patient came with, actually with this x-ray. But actually, as Bipina showed, that the normal PA view looks like the standard PA view looks like this. So you can see now the carpal bones are arranged much more nicely, and it's not easy to miss any of these injuries compared to this X-ray here. So that is the importance of taking an appropriate X-ray. And again, all these has been alluded earlier. You need to check all these, the concentricity of this arcs here. So anything mismatch, any mismatch you see here definitely means there is something going on there. Now, in the lateral view, Bipin spoke about the SPC lateral, where the pisiform is here, SPC lateral, the capitate is here, which is a true lateral view. But also you need to check this, the angle between the scaphoid and the lunate. The lunate should be sitting right here in the neutral position, and the normal angle is about 30 to 60 degrees. So to understand carpal instability, this is one of the main key findings we need to remember. The other thing is to also know the normal shape of the lunate. If you see, the normal shape of the lunate is almost a trapezoid kind of a thing. And if you have a patient who comes with this and then it doesn't look normal to you, and then something is happening there, which means the shape is changed. It's more towards a triangular shape, means the lunate is tilted either dorsal or roller, it might be subluxated. Now, so the same patient came to me, the first thing I would do is to change this X-ray, right? So from an AP, we need to take the right X-ray, which is the PA view. And if you carefully look at the lateral view now, you would see that this lunate is tilted slightly dorsally there, and that scapholunate angle is definitely increased. Now, if somebody would come like this, I don't think anybody would miss the carpal instability. This is a static instability. None of us should miss this, the gap, because again, in a normal X-ray, all these gaps should be equal. It's about 2 millimeter, 1 to 2 millimeter. That's the cartilage thickness there, and it should be equal. And anything increased means, again, you need to have a suspicion. And this is definitely much wider compared to any of these. So it means there is definitely a problem. So nobody will miss this. But what people will miss is something which is more dynamic and which is not being seen. So if your clinical examination points to a scapholunate pathology and X-ray is normal, the second point is you have to bring out the dynamic instability as much as possible, or you need to image further, which is usually an MRI. The more easier thing is to bring out a dynamic instability, which means that you need to stress that, try to recreate or provocate the injury by what is called as a clench grip use. So this is the exact way to take the clench grip use or the clench fist use, and then you would have to always compare We always do both PA and AP. Sometimes it is seen better in AP actually, but then you would see the difference of this. So this is where you are trying to getting into the dynamic part of the instability, which means that if the capitate, if there was an injury here, the capitate will try to push this when you stress this and the gap increases. So this is the dynamic scapho instability which we talk of. Now, the lunate goes with a stronger person. Now, if there is an injury somewhere here between the scaphoid and the lunate, or the scaphoid is fractured like what Abhijit was talking, the lunate will now move with the triquetrum, which has got a tendency to extend, which means that's why the lunate will go with the. So if you have a scapholunate injury like this, the lunate will now go with the triquetrum and the scapholunate angle will increase here. And that is your classical DC deformity. So the lunate is dorsally tilted in the intercalated segment, which is this here, and it is there's an instability. So if you look again, this is the normal way the wrist goes from radial to ulnar deviation, right? From to ulnar deviation. So you see the scaphoid extending so nicely here in ulnar deviation, and then this whole complex will push this scaphoid here to flex here as it goes to the ulnar deviation. Now, if you see this, can you see this now? So here the gap is increasing here, which means there is a problem here, very commonly associated with distal radius fractures. So don't look at always the distal radius, always look at one joint above here and then see this. So if you have scapholunate injuries, isolated injuries, then they require reduction, pinning or repair. And if you have commonly associated distal radius fractures, you have to treat the distal radius fracture, and of course you have to treat this. So you need to keep the lunates in the neutral position, whichever way. So generally we pass a radiolunate wire and try to keep it in the neutral position like this, and then try to pin this down here along with the scaphoid here. So this is one of the commonest way of doing the reduction. And if you want to keep the scaphoid extended, you would pass another wire here between the scaphocapitate and then remove this radiolunate wire here like that. And at the end of your surgery, they need to move together. So that gap should disappear here, and they need to move nicely like this. And here again, the scaphoid should be in the neutral position like this. So this is the simplest way of treating like this scapholunate ligament injuries. Now, it can be that it's not always scapholunate, it can be lunatotriquetral. And once that happens, now the lunate is now moving with the scaphoid, which means it's got the tendency, normal tendency to flex, which means you see a lunate which is flexed on the palmar side. So this is the VC kind of deformity where the scapholunate angle becomes less than 30 degrees. So the DC and VC, we always used to, hate this terminologies, but it's a very simple concept that it's an intercalated segmental instability. The intercalated segment is basically the proximal row bones linked to each other by the ligaments, and the dorsal or volar in the DC or VC refers to the direction which the lunate will take. And both the DC and VC involve proximal rows and are ligamentous predominantly. So it's called as carpal instability dissociation. So there is a dissociation there in the intercalated segment, and lunate is the key bone there for this in the proximal row. Now, the fourth concept you need to understand, where we should not miss the carpal instability, is how the force will now progress. So this is a very nice cadaveric dissection, this article, if you read, where a cadaveric study where the injury starts on the radial side and prolongs to the ulnar side. Now, there are many mechanisms involved which can bear their ulnar side mechanisms are also involved, or it can go through the bones, or it can go through the lunate, or it can go below this also. But this is the commonest way the injury progresses in a wrist injury. Now, here is another patient with high energy trauma, hyperextension injury, painful swollen wrist. And again, so the same checklist which I told. Now, if you see the lunate, it looks triangle. It's not looking trapezoid. The hilus arcs are damaged, right? And then the capitate is not there on the lunate here. So capitate has gone dorsal to the lunate. If you draw the axis here, which means that there is everything around the lunate is probably injured. So this is what is called the lesser arc injuries, where the force now goes along the ligaments here and then goes out. So here all the ligaments are damaged, the scapholunate, the lunatotriquetral, and connections between the capitolunate here. So everything around the lunate dislocates, dorsal or volar. So perilunate dislocation is not an isolated injury, but it's actually a stage in progressive carpal destabilization. These injuries are missed initially because, as I said, or I showed, the complex anatomy of the wrist itself. And accurate interpretation of radiographs is the key. There's another case where you now see again the lunate is looking triangle there, the Gillila's arcs are damaged, and you see a fracture there. So this is the same thing which has happened here. The capitate is dorsal here. Very rarely there are volar lunate, perilunate dislocations also. So what has happened is there is a fracture there. So means the force has gone now through the bones and not just through the ligaments. So these are called as greater arc injuries, which are perilunate dislocation with fracture. For example, we call it as a trans-scaphoid perilunate dislocation. So you know what is perilunate? The word trans is used to any fracture going through a particular bone. It could be trans-scaphoid or it could be transcapitate, any of these things. And it can be dorsal or volar dislocations. Now, the basic principle of management of this is appropriate X-ray, as we said, and then a traction view is sometimes helps us with this, and sometimes definitely a CT scan will tell you where the anatomy is. Close reduction and cast is one option, but most of the time we goes for close reduction and percutaneous spinning. The best would be open reduction, internal fixation, and ligament repair. So this is one way of doing a close reduction, the Tavernier's method, where you hyperextend the wrist, increase the deformity, and try to get that capitate back into the lunate there. Technique of percutaneous, as I said, again, keep the lunate in the neutral position, try to fix the scaphoid, okay, and then try to pin down the lunate on all sides. So you have a scapholunate wire coming here from the lunator-triquetral here, and scaphocapitate wire here. So the lunate should be in the neutral position, and we try to fix all the bones around it with these wires like this. So if you want to do open reduction, so it is a classical dorsal perilunate kind of a dislocation. And if you see this, you need to open it up with a classical approach to the wrist joint. And once you open it up, what you actually see is the capitate. You don't see lunate here because the capitate is dorsally dislocated here. And if you gently give some traction there, then you will start seeing the lunate somewhere hidden below. So this was dorsally dislocated. The lunate is more in the volar side now. Sometimes you see these kind of injuries, the chondral damages here in the capitate here, and they could be the reasons for future stiffness and arthritis. And once you do that, we gently try to reduce this capitate back, and then you get the wrist movements, and then you need to come and check exactly what's happened to the ligaments. So if you check this, there is a damage here. There's a linotic fracture. There's the LT ligament which is damaged. So these are the ones which require so that fracture, that is a scapholunate here, ligament here, and this is the LT ligament here. So this scaphoid needs to be fixed here. The LT has to be repaired, and then the lunate has to be reduced nicely back into this position. And sometimes you might have to go on the volar side also, sometimes if it's very difficult to reduce from the dorsal side. So always be ready to, increase your incisions on both dorsal and volar if the reduction doesn't come. And once you do that, you do the repairs, you do the fracture fixation of the scaphoid, you do the repair of the ligaments here, okay, and suture back the capsule nicely there. And at the end, this should be that the whole thing has to move in a nice way. Very, very important. So that's the. Now there could be another situation again with a very painful wrist, swollen wrist, but patient also has some tingling and numbness in the hand. That is the history, and you see an X-ray like this, you know that the lunate is completely out now and is probably compressing the median nerve. So it's actually a spectrum. So you have a perilunate kind of dislocation, then this sometimes if the injury goes on, this lunate can get subluxated, and finally it can dislocate. So perilunate to lunate dislocation is a complete kind of spectrum you see, and the same thing happens here where the dorsal ligaments are damaged, then the radiolunate ligaments also get damaged. So you have these short radiolunate and long radiolunate ligaments here, and that gets damaged, and finally the lunate dislocates, which is classically called as a spill teacup sign here. As I said, the median nerve can be compressed. The median nerve is being tented here by the lunate here, and just if you retract the nerve, you will see that the lunate is right there. So you might have to start with an volar incision and try to reduce this and relieve the compression of the median nerve here, and then go back dorsally and do the same thing and repair the ligaments. So what's the prognosis? Most cases are still frequently missed at presentation. It results in a chronic wrist dysfunction, degenerative arthritis finally. Delay in treatment influences long-term outcome, but open reduction is still worthwhile. Even if they come about 1 to 2 months late, it's still worthwhile to do an open reduction. Late repairs generally require both dorsal and palmar approaches. Many reconstructions or options are available if they come late, and if reduction cannot be accomplished, or if there is significant cartilage damage, either a proximal row carpectomy or partial wrist fusions is probably indicated as a salvage procedure. Thank you so much.